Okay, so let me Zuya home.
Is you good evening, all. Thank you very much for joining early. We'll be starting by 8 p.m. So let's just try to put our things in order so that once it's time, we start. Thank you, sir. Our editor lecturer for being here, sir. We recognize you, sir. At the appropriate time, we will introduce you, sir. Good evening, all.
Yeah, thank you very much, Dr. Busui. Can I share screen? Oh, okay, I can, yeah.
Take the noise, not the noise. Take the noise, not the noise. Good evening, good evening, all. Good evening, ladies and gentlemen. Good evening, our Herodex lecturer today, Professor Yomi Ogun. Good evening, our moderator, Dr. Oluwatui. Good evening, esteemed colleagues that are joining. While we wait for others to join us, we will be starting with a national anthem. I will just okay, we'll be starting with an opening prayer. I want someone to quickly give us an opening prayer, then the moderator will take off from there because we have a long journey to go.
Can we pray?
Yes, sir.
I am Ademini. Let us pray. Our Father, in the mighty name of Jesus, we commit this program into your hands, O Lord. Daddy, direct it yourself in the name of Jesus. Daddy, take absolute control of everything we are going to share here in the mighty name of Jesus. At the end of everything, O Lord, let us have every cause to give glory to you and you alone. In Jesus' wonderful name we are praying. Amen.
Amen. Oh,
Yes. Good evening, everyone on the call. It's exactly 7:59, and we'll kick off at 8 o'clock exactly. So it is 8 o'clock now. So Good evening, everyone, once again. I guess we would allow the others to join in even as we proceed. So, you're all welcome to today's webinar. This webinar is organized by the Hypertension Awareness Forum. The forum was founded by a medical doctor, Dr. Oladunjoye Busuyi, in April 2023. It is a support group that was birthed out of the desire to disseminate accurate medical information and content to the public, to debunk false information and beliefs, and to help facilitate care and referrals. Of utmost importance, it's the fact that it is a non-profit forum. Today, we are going to be looking at one of the major complications of hypertension, which is stroke. Interestingly, hypertension is the most important modifiable risk factor of stroke. And according to the Federal Ministry of Health, Nigeria, the overall prevalence of hypertension in Nigeria is a whopping 38.1%. And approximately 70% of stroke cases occur in low and middle income countries like Nigeria, with the stroke prevalence in the low and middle income country greater than 12%, and a prevalence in Africa of about 316 per 100,000 people. So for this reason, we are having a timely conversation as we join the world to commemorate the World Stroke Day. Today, Tuesday, 29th of October, is the World Stroke Day. And to help do justice to this topic, we are joined on this platform today by an Amazon in his field. He is cool, calm, and collected. He's a gentleman and is a professor par excellence of the Department of Internal Medicine and the neurology unit of the Lagos State Ogun. So join me as I welcome him to the call. Sorry, network is playing tricks on us. I'm using another Zoom identity. Please bear with me. So, I was going to read the citation of Professor Yomi Ogun. Professor Ogun Abayomi is a native. Okay. Professor Ogun Abayomi is a native of Lagos State. He's a distinguished professor of internal medicine and neurology and an honorary consultant, physician and neurologist at the Lagos State University College of Medicine and Teaching Hospital. With over 40 years of clinical teaching and research experience, his expertise spans internal medicine, neurology, and infectious diseases. He has authored several books and over 100 scientific publications in national and international journals, and is recognized as the leading neurologist and authority on stroke, neuro-HIV, and neurophysiology. Professor Ogun has attended numerous fellowships, including from the African Academics Network 2023, the Academy of Medicine Specialties of Nigeria 2021, the American Academy of Neurology 2019, the World Stroke Organization 2018, and the Royal College of Physicians of Edinburgh 2017. Additionally, he holds several prestigious roles, one of which is the past president of the African Academy of Neurology 2017 to 2019, president of the Nigerian Stroke Organization since 2000.
Mayo,
Former member of the World Stroke Organization Board of Directors 2016 to 2020, and Nigerian delegate to the World Federation of Neurology 2010 to 2021. He also served as president of the Nigerian Florida Neuroscience Partnership and founding director of the Center for Special Studies, HIV Caregiver, in collaboration with New York Presbyterian Hospital, University of Cornell, Columbia. He has been an examiner for the undergraduate and postgraduate medical exams in West African College of Physicians, past editor for Nigerian Medical Practitioner, and a two-term provost at Olabisi Onabanjo University. His notable contributions include a 51-page inaugural lecture at OOU in 2009 on brain health titled Of Neurology Brain Attacks, the Good, the Bad, and the Ugly. His early education was at St. David's Anglican School, where he achieved distinction, followed by Lagos City College and the University of Ife, graduating in 1983 with first-class honors in BSc Health Sciences. In addition to his academic roles, Professor Ogun is a principal investigator for the NeuroAid Safe Treatment Registry in stroke and actively serves on national and international committees for immunization safety and COVID-19 research. By now, I believe we are joining our hands as we welcome Professor Ogun Abayomi to take up the mic and continue with his presentation. Thank you very much.
Yeah, thank you very much, Dr. Olamide Oluwatuyi, for that brief introduction, and also making an euphoric comments, reminding me of all these things. Okay, I mean, it was making me to almost becoming euphoric with a swollen brain. I felt I needed medical decompression by taking the dexamethasone IV. However, thank you very much. I'd like to appreciate the members of this team, the Family Medicine Department, and also the Hypertension Awareness Forum, organized by Dr. Busuyi. And also appreciate that one is an NGO, and it's mainly for health education of the public. I think that's a very great one. So I feel very highly elated to make this presentation. So distinguished colleagues, distinguished ladies and gentlemen, and I also noticed that we have in our midst, my big boss is also there as well. My teacher, my mentor, taught me neurology from infancy, Professor Kayode Udishote. Good evening, sir. You're most welcome, sir. And well, I bow and tremble, sir. Then we also have Jimmy as well, also with us. Well, I know I have 45 minutes to give this talk. Well, I'll try as much as possible to cover the essentials. And I also know that it's a mixed audience. We have the low, we have the high, we have the mighty. And I think in this regards, I'll try go basic and also try to just put some highlights, fine-tuning as much as possible. So without much ado, I think we'll start. Though I must say, giving a talk on stroke could be a cause of verbal diarrhea for me. Yeah, I'll try and make sure that I can curb the diarrhea as much as possible. especially just coming back from the World Stroke Congress, which was held in Abu Dhabi just a few days ago. So let's start. Yeah. So what I intend to cover, I mean, more so with a background of mixed audience, to talk about what we need to know, what we're talking about. Highlight the risk factors, and then talk about the stroke management, keeping in view a multidisciplinary approach, and of course, make reference to neuroplasticity, and then emphasize on prevention, more so since it's on health education of the public. Then, of course, end with the good, the bad, and the ugly. I intend to appreciate also the time trend definition changes, and then some peculiarities of stroke in the Black scale, and then make emphasis on epidemiologic transition as well. I'll give the highlights as much as possible. Well, stroke, of course, is an ancient disease, right from the days of Hippocrates, amongst other scientists as well. But the terminology stroke actually came into the medical literature in 1869 by Koch. The common thing we say commonly is to say 1 out of every 4 will have a stroke, and they do not be the one, okay? I must say that years ago, 1999 particularly, before the 2012, you're seeing 1 in 6. The reference to 6, when we talk about stroke, I mean, it sounds biblical as well. If we spell the word stroke, okay, there's 6 letters there. And that will take one to the book of Revelation 13, verse 18, that talks about 666, okay? So we started by saying 1 out of 6, and then now we know it's 1 out of 4 because of the epidemiologic transition, which we'll talk about. And also, we're saying one every 6 seconds. As not developing stroke somewhere in the world, but now we know it's every 3 seconds as well, just to reflect the epidemics, okay? And then we also used to say that that every 6 seconds, someone is dying of stroke somewhere in the world. And then also annually, about 6 million people will die from stroke, whatever we do. Another 6 million people will become disabled. And another 6 million will survive, like 1 out of 3. Okay, going further, if anyone develops stroke peradventure, it's not like malaria that will go in 3 days. It takes 6 weeks to 6 months for optimal recovery. Okay, and then still on the 6 as well, there's something we call endovascular thrombectomy. This session on stroke, we just need to liken our brain to that of a plumber. Okay, the plumber wants the pipe to flow in the tap. If there is no water flow in the tap, it's either because it's blocked, and what the plumber will do is to put in a chemical to dissolve the clots. Okay, those are clot busters, or he actually gets the plunger to remove the clot. That removal of the clot is the endovascular thrombectomy, which also must be done with some aspect score we call much more than 6. Aspect score is talking about the Alberta Stroke Program LECT. Okay, and then also the NIHSS score was more than 6. The patient presenting again less than 6 hours. Okay, this is all talking about 666. Though we now know that, I mean, for the same procedure, they don't study says 24 hours, the fuse says 16 hours. Before I go further, I also need to emphasize that Hippocrates actually used the word apoplexy because stroke was seen as sudden, struck by violence. Could be seen as a way of dying, spiritual attack, the witch or the wicked mother-in-law or the stepmom theory that the individual had offended the gods or the goddesses, the small g now, and now became unable to speak or move parts of the body. What the Yorubas would call Agbero, Ota, Ofa, and what have you. No wonder that may inform why when patient develops, rather than come straight to the hospital, the first port of call may actually be to visit the spiritualist, amongst others, which deprives them of the time window for us to do what we call thrombolysis. Okay, we'll talk about that later. In terms of the epidemiology, there's some peculiarities in the sub-Saharan Africa, and this has been changing globally. We're not in favor of the low middle income country, I must say, whereas the incidence has been declining in the high income countries. In the low middle income countries, it's been on the increase. And this is because of a lot of neglected burden of non-communicable diseases which have been on the increase. Obesity is on the increase, dyslipidemia, diabetes, hypertension, amongst others. There's the epidemiological transition, which I made reference to. This relates to the fact that people are now living longer, there's aging population, increasing longevity. Population is also growing as well. And there's rapid and unchecked urbanization and industrialization. Then accompanying lifestyle changes, smoking, alcohol, becoming of the order of the day, as well as physical inactivity. So something we call DALYs. That's the disability adjusted life years, which is the year of life lost. Unfortunately, in the black skin, our stroke occurs about 15 years earlier compared with the Caucasian. So that's already 15 down, plus years of living with disability. So on a global scale, the DALYs had been on the increase by more than 48% in the black skin, whereas these DALYs in the high-income countries have declined by 25%. Both the incidence, the prevalence, and the death as well. If 100 people should die from stroke today worldwide, almost 89% of them will be from low middle income countries. This, of course, has made stroke to be the second leading cause of death worldwide, okay, particularly in the low middle income countries. Well, in the light of these epidemics, the WHO, as well as the WSO, set up a committee to look into PWPS, that's the population-wide prevention strategies. Then some task sharing, as well as health system re-engineering, so that at least you could also involve some of the policymakers in taking decisions towards rolling back stroke. This table tries to give highlight of what I've said before. 1 every 3 seconds, one is developing stroke somewhere in the world, and that 1 out of 4 people you meet on the highway will come down with stroke in a lifetime. And the 5 leading stroke risk factors: your hypertension, your obesity, dyslipidemia, diabetes mellitus, air pollution, and then smoking, amongst others. There's some peculiarities of stroke in the African ancestry. We have that enhanced genetic predisposition to stroke. So being a black skin, being a male, is a risk factor on its own, in the first instance. Then, of course, the types that we see, though globally, cerebral infarction is the commonest, about 80%, followed by intracerebral hemorrhage, about 15%, then subarachnoid hemorrhage, about 5%. I must say, proportion of hemorrhage, particularly ICH, we see in our environment is like 1 out of 3. Okay, so a little bit higher, but still coming behind cerebral infarction. Then the outcome of a stroke is also more severe. The outcome is also poorer as well, and of course about 15 years earlier. This, of course, has been confirmed in several studies among the African Americans and also in the multi-ethnic South London stroke registry as well. But some of the factors that could be responsible for this variation in rate could be: 1, the healthcare seeking cultural practices. Okay, we have some lackadaisical attitude for health, especially the male subjects. Okay, and then of course differential access to healthcare services, and then some environmental causes, including infection, pollution, amongst others. So just talking from basics. The definition of stroke came up well over 50 years ago, 1970. Talks about focal or global cerebral dysfunction of vascular origin lasting more than 24 hours. And they have the three types of stroke: subarachnoid hemorrhage, cerebral infarction, ICH. Those CVST, cerebral venous sinus thrombosis, also came. This excluded TIA on the proviso that one, it occurs less than 24 hours, exclude brain tumors, which are seen as stroke mimics, and subdural hematoma, also stroke mimic as well. The term CVD is a parent term, okay? And all this having the components under the CVD. The CVA is stroke, okay, but like I said, CVD is a parent term under which you have all these cerebral venous malformation, subdural will come in there, and what have you. Yeah, this takes me to describing what we say stroke-like syndrome. That is making reference to a patient presenting with hemiparesis, one-sided weakness, facial asymmetry as well, until proven otherwise could be said to have a stroke or a stroke mimic. Okay, imagine if I'm retroviral positive and I have TB meningitis and I have tuberculoma on my other on my contralaterals, I'll present stroke-like. That's stroke mimic. Okay. Ditto for cryptococoma as well, ditto for toxoplasma abscess, cerebral lymphoma, sarcoma. So once they are non-vascular, they're seen as stroke mimics, and once they're vascular, then they are seen as stroke. In 2002, where we made reference to the fact that the cardiologist will not wait for 24 hours before they make a pronouncement of myocardial infarction. So why should a more superior organ wait for that length of time? So we consider reducing the time frame between TIA to be 1 hour, also keeping in view that from experience, 90% of TIA will last about 10 minutes and will resolve within 30 minutes or within 1 hour most times. If they last more than 1 hour, chance of resolution is actually very low, about 15%. So we made efforts to change, but then that will entail you have to change all the epidemiological data amongst others. And of course, that didn't stand the test of time. In 2009, we considered tissue-based and then time-based, keeping in view that neuroimaging emphasis must be made. That you have a patient who has a stroke presentation and you have evidence of infarction, not minding the time frame, then you can see, oh, this patient has had a stroke. In 2009 and 13, this came up with the definition, which I think still stands, that, well, the 1970 definition talks about global or focal. The word global, it was taken off, okay? Global making reference to things like pre-syncope, when you have a global cerebral hypoperfusion, okay? The stroke must be focal. And also no trauma, okay? Once you have trauma, it comes under traumatic brain injury. And that, of course, excludes like a subdural hematoma from being seen as being stroke in any way, most because it's more commonly post-traumatic, and of course, outside the brain. Then the neural tube structures are what are implicated. So that means the brain, the spinal cord, and the retina. So you can have an eye stroke as involving the retina. That's one of the anterior circulation stroke, because the very first clinical branch of internal carotid is the ophthalmic artery. And then from there, you have the central retinal artery, which can get occluded and cause a stroke of the retina, what you call eye stroke. That is affecting the spinal cord and also the brain as well. Well, this takes us to exclude neural crest structures. This informs why a patient with Bell's palsy, okay, is not seen in any way as anything near stroke, neither mild stroke nor whatever stroke in any way, okay? It's not stroke, it's coming from the neural crest structures. And over and above that is the fact that see as some of the symptomatology of stroke, the acronym BFAST, of course, there's only the facial asymmetry. The other BFAST are missing. And then Bell's palsy, of course, is not vascular. Okay, more often with herpes simplex or herpes zoster, geniculate herpes. So it's not seen in any way. It's nonsensical to refer a patient with Bell's palsy to say as mild stroke or what have you. Then going further, the time definition now became a secondary consideration when neuroimaging unavailable or inadequate. I also must say this, before 2016, there was less emphasis even from those in the Ministry of Health, amongst others, the policymakers. Recognition of stroke has been a brain disease, was put under cardiovascular disease. And that radiologist to be taking care of stroke as well. I mean, liking it to coronary artery disease, which of course it didn't stand the test of time. So 2016 was taken off cardiovascular disease and under the brain diseases as well. So we mentioned neuroimaging. CT scan is the imaging of choice. I mean, it's cheaper. The time frame to get this sorted out is far, far, far lower than when you do an MRI. So, and you, of course, you need to do a CT scan is a sine qua non, a patient coming down with stroke. I want to exclude a stroke mimic, all those we have said, the tuberculoma, cryptococoma, etc. And then to exclude an hemorrhage, okay? You see an hyperdense lesion like this. So that means rationally for doing your immediate CT scan is to exclude a brain, a stroke mimic, exclude an hemorrhage, because you really want to thrombolize, that's your aim. Once you have hemorrhage, there's no need for thrombolysis. And then 3, you also want to exclude a large infarct. You see an hypodense lesion, which could connote a large infarct, which must have been there for a longer while. You have a time window for you to thrombolize your patient. And the risk of hemorrhagic transmission is even higher as well. So it's a no-go area. If you have a normal CT, then go ahead and do your thrombolysis, emphasizing that stroke as a clinical diagnosis. If you have your hyperintensity in the subarachnoid space, that's your subarachnoid hemorrhage, okay? I've covered this. Well, the ITH versus BBC. BBC not born before Christ, but born before computing. You go to your village to see your babalawo, and this is the kind of thing you see. And of course, this is also the jet age. It's the wireless. They're now having babies delivered without umbilical cord, okay? Those are wireless models of babies. So in this regards, just to make it simple in terms of understanding the pathophysiology, pathogenesis, but if you understand the pathophysiology, pathogenesis, it becomes a lot easier for you to treat. If you believe in spiritual attack as the pathogenesis, then you need to see the spirituality. But if you believe in these 3 P's, then of course you can apply it to your treatment. So let's take it from the passenger, that's the blood flowing. And then the passage, that is the pipe. And then the power, that is the brain. When you give your patient blood thinners, your antiplatelets, talking about allowing the blood to flow for the passenger. When you give your clot busters, your thrombolysis, again, you want the blood to flow. Or when you do your endovascular thrombectomy to remove the clot, talking about the passenger. Then for the passage, that's the wall itself. When you give your statins, okay, they stabilize the endothelial plaque, anti-inflammatory properties, amongst others. Okay, you're working on the passage. And then when you also do what you call carotid endarterectomy, when you have carotid stenosis, what you're working on is the passage. I must say the power, that's the brain cells. Okay, we had ignored this in the managing patient with stroke almost forever. Well, my teacher then taught me as well, Professor Dushote is here, that the brain cell do not regenerate, okay? And we also gave some teaching as well. But now we know that the brain cells can regenerate. That even in adult brain, there's some neuroprogenitor stem cells in the periventricular, subventricular region of the brain. And those stem cells can be stimulated and they will migrate to the site of injury, peri-infarct area, and there will be axonal sprouting, there's axonogenesis. Even synapses that have not been active, they become activated. So there's synaptogenesis. So you have neurogenesis. So there are new neurons being formed. I say this on a lighter note. There are 3 subspecialties in internal medicine. We talk of neurology, cardiology, and others. What that translates to is that if you lay new neurons, there are new neurons, there's neurogenesis, there must be angiogenesis, there must be new vascularization. You must form new vessels. So that you can sustain the neurovascular unit hypothesis. So a medication that stimulates this BDNF, they also same that stimulates what you call the VEGF, the vascular endothelial growth factor as well. So they'll assist in forming new vessels as well. So stretching that further, everything about stroke has to do with flow, okay? You define cerebral infarction as occlusion of the vessel, and you put a caveat there with emphasis, in the absence of adequate collateral circulations. Those collateral circulations are seen as back doors, okay? Of course, there are always two sides to the door. I mean, there is the point of entry, and also there's the point of exit. So this, the back doors are seen as the collaterals. And I must say, if you have adequate collateral circulation, then there'll be no infarction. So for the collaterals, those back doors, the three categories, there's the primary first degree circle of Willis, and there's the secondary degree leptomeningeal and ophthalmic artery. And of course, there's the tertiary and the angiogenesis I already mentioned as well. One of the things you must achieve, and that's why you talk of permissive hypertension. The patient come down with stroke, as an infarct, you don't want to crash the blood pressure because you want permissive hypertension. Okay, one of the rationale is to keep those collaterals, those back doors open. Okay, of course, amongst other reasons. This is just talking about all I've said before. The passenger, the passage, reference made here to vasospasm, which relates to either patients with migraine or even patients that have subarachnoid hemorrhage. Okay, patients with subarachnoid hemorrhage, they have what we call a delayed cerebral infarction. There's a delayed vasospasm, which occurs typically day 4 to day 10. So it's still relevant for the passage there and then the power itself. For long-standing hypertensive, they develop lipohyalinosis and then develop Charcot-Bouchard aneurysms, which are tiny aneurysms and arteries. Like could get blocked with a microatheroma, or they could bleed and they have the epilation sites, the pons, the internal capsule, the thalamus, and the cerebellum. Okay. So talking about the vessels, intracranial and extracranial, I mean, we have smaller vessels. We are more affected, it's commoner in Black, and that's why we have more strokes. Unlike the Caucasians, of course, which the extracranial vessels are more affected. No wonder they have more of TIA, more of urinary artery disease, amongst others. So, talking about front door and back door, I think it's a reminder of Bob Marley. If you are talking to, well, you are talking to now. Why do you look so bad? And one door is closed, don't you know? I'm so bad. Yeah, so if the front door is blocked, then why not open the back door? So that's the take-home message there. And that relates to the permissive hypertension that I emphasized, okay? So concept of course, the following the occlusion, there will be the central core where you have necrosis. There will be the penumbra, okay, where you have ischemic cells that can be reversed if you improve the blood flow. And then you have your benign oligemia as well. So this is still taking us through the pathophysiology, the blood flow, 55 mils. And then if it goes less than 25, I mean, EEG diffusely slowed less than 15, physical activity will cease. That's a functional threshold. And if you improve blood flow, you can recover that. But if it gets less than 10, it becomes irreversible. That's the morphological threshold. I've mentioned permissive hypertension that don't crash the blood pressure with cerebral infarction. BP 185, 105. And then two other reasons why that is so. Also because if you look at this simple equation, it says CPP, that's the cerebral perfusion pressure. That's the difference between your mean arterial pressure minus the intracranial pressure. And what that is saying is that in patients with stroke, ICP has gone up because of either cerebral edema accompanying the peri-infarct, or you have the space-occupying effect of the hematoma. So if this has gone up, and then you want to maintain cerebral perfusion, then your MAP must go up. The second reason, of course, or the third reason now is because of this autoregulation, which is lost post-stroke. And that can be on for up to 3 weeks. The brain is a very self-centered organ. It's 2% of the body weight, takes 20% of the blood volume, takes 20% of the oxygen. Does not want any excess, any extras. The minute arterial pressure goes high, cerebral vessel will vasoconstrict. Does not want overflooding of its circulation. So you don't develop hypertensive encephalopathy. When arterial pressure goes down, you will vasodilate, okay? Yes, to at least to allow sustain the perfusion, but you've lost this autoregulation. So your cerebral perfusion now become pressure passive, and that's the rationale for what I've said. Looking at the major risk factors, I must say it's very broad spectrum. You have non-modifiable, and then you have modifiable as well. I must say 90% of the modifiable, okay, things you can modify, okay? The non-modifiable include your age, your sex, your gene, genetic predisposition, and then you have hypertension, of course, damages 4 organs, the brain, the heart, the kidney, and the eyes, okay? And you have some of the endpoint effect as well. And also we've mentioned the 5 leading high-risk causes, hypertension, sugar, cholesterol, amongst others. Then if we look at stroke in the young, which of course has been on the increase in our environment lately as well, includes substance abuse, includes a patient with sickle cell genotype, patient with valvular heart disease, mitral valve prolapse, PFO, patent foramen ovale, amongst others as well. And of course, lately, some new risk factors, including electronic cigarettes and obstructive sleep apnea. OSC is a risk factor to stroke on its own and even affects the prognosis as well. Then, of course, you have some infection, neuro-COVID, HIV, amongst others. This, I think, is talking about the cardiac lesions, which I think for this mixed audience, we can skip this. Okay, and just to also remind us, HIV, AIDS, neuro-COVID, the pathogenesis, when COVID came, we're seeing quite a number of stroke cases. The overlap between the two of them, in addition, COVID will cause what we call arrhythmogenic cardiomyopathy. Okay, that you have patients that had enlarged hearts and then had cardiac dysrhythmias with tachyarrhythmias, bradyarrhythmias, amongst others. Etiology for the risk factor to ICH, we must remember the elderly with cerebral amyloid angiopathy and a host of other conditions here mentioned as well, including substance abuse as well. Then alcohol also play a role as well and has a relationship with those 3 types. So linear relationship with subarachnoid hemorrhage, with intracerebral hemorrhage is a U-shape. In other words, if you're a teetotaler, the risk is high. You take low doses, it's protective. High dose, then it goes up again. And then the J-shape for cerebral infarction. Well, it's this is just to emphasize the permissive hypertension that I've mentioned already, and this other covers. Having said that, there may be indication for you to reduce the blood pressure if there's features of extracerebral complications, including dissecting aortic aneurysm, ischemic heart disease, pulmonary edema, or a rapid decline in renal function. We need to appreciate, before we talk about the management, that there's some class of recommendation and there's some level of evidence, okay? Class 1, what you should do, okay? For thrombolysis, stroke unit, or those are sine qua non. Class 2, consider it 2A as per most experts, okay? Your mannitol to reduce intracranial pressure may come in there. Your dexamethasone conflicted may come in under 2B. 3, don't do it. Like want to give aspirin in the patient with ICH, okay? And the level of evidence, you have 2 randomized trials, okay? B, when you have just 1, there's C, expert opinion or case report. To remind that managing patient with stroke is multidisciplinary, okay? It's a teamwork. That's why we say time is brain, brain is time, and then brain is team as well, and team is brain. Of course, it encompasses the neurosurgeon, the neurologist, the stroke nurses, the stroke pharmacist, physiotherapist, the OT, the SLT, social worker, the nutritionist. And then on a weekly basis, if you have a stroke team like we have in LASUT, on a weekly basis, everyone meets and discuss all the patients, okay? It's a teamwork and team standing for together, everyone achieves more. This is trying to talk about the roadmap, which I think I'll emphasize later. Well, just the guideline, they keep modifying it, okay? And the latest modification was 2021. We talked about sonothrombolysis, okay? Now we believe it's of no effect, okay? The ultrasound can break some of the clots. CRP measurement because of the inflammatory process you have. Hyperhomocysteemia, we used to give folic acid in those days to take care of this, but then it's not been seen as a significant risk factor as well. Factor 7A, for patients with intracerebral hemorrhage, okay? Again, lack of efficacy, so that's been taken off. And the patient has carotid endarterectomy where you have more than 70% stenosis. You should do this within 40 to 7 days, but lately it's extended to up to 2 weeks as well. So I've made this emphasis on subdural hematoma. This is cerebrovascular disease taken, but then in fact it is trauma, often post-traumatic, and it's outside the brain. So at best, it's a stroke mimic, a stroke-like syndrome, okay? It's not stroke. Well, I gave this, one of my students, this assignment on a Friday. That I should write an essay on dog, and he brought this to my glass house, okay, on a Monday morning. I don't know what to do with this candidate. Maybe the house may advise me, okay? So in terms of clinical features of stroke, which I think will be relevant to those in family medicine, a clinical diagnosis of stroke, we have said it all with all those focal, not global, okay, affecting neural tube structures, and then the time frame as well. Pathological to see whether it's an hemorrhage or an infarct. That should be at the back of your mind. When you see a patient with stroke, you must make a pathological diagnosis before you can proceed, okay? And then etiological risk factors, all those ones we've mentioned, then anatomical diagnosis. We've just fly through this. In terms of the clinical, just to remind us of the acronym, BFAST, okay? That's why I dismissed the Bell's palsy, because that has to do with facial asymmetry. B stands for balance loss, particularly for posterior circulation stroke. Okay, you could become unsteady in terms of your gait. Then E for high vision loss, your anterior circulation stroke, your maurosis fugax, which again, we have mentioned as well. Then facial asymmetry, arm weakness, speech difficulty, then says time is brain. They say time is brain because there are 200 billion neurons in the brain, and every 1 minute you waste, you're losing 2 million neurons. That's about 12 kilometer fiber length. So time is of essence when it comes to stroke. So you must know this acronym. When you're doing your health education to the masses, this must be a take-home message. They can't remember BFAST, they can at least remember how to spell stroke. So S, can the patient smile? T, can the patient talk? R, can the patient raise the arm? Okay, and then you're there. This is just emphasizing the BFAST again. So for the pathological criteria, okay, if a patient has a wet stroke, in other words, the pipe has burst, okay, there'll be sudden increase in intracranial pressure. And of course, that patient is likely to have loss of consciousness, have headache, and vomiting as well. Then that tends to occur suddenly, unlike infarct, which may be more gradual. And then hemorrhage also like to be moderate to severe hypertension, like those with cerebral infarction, which tends to be more gradual, okay? And then when you have your bloody CSF, it's more supportive of CH, okay? So we should be able to clarify that from the very point of entry so that you know whether you have to thrombolize your patient or otherwise. In terms of anatomical, maybe too complex, but just to say that for ICH, I already mentioned Charcot-Bouchard aneurysm and the predilection site, putamen, cerebellum, thalamus, and then the pons, okay? And then, of course, is that if stroke is cortical, going to look out for your cortical sensory function. Otherwise, below that, you talk about the subcortical, your internal capsule, your thalamus, or the basal ganglia. Internal capsule, there'll be dense weakness. Thalamus, there'll be some sensory, hemisensory dysfunction. Basal ganglia, some dystonia or posturing, dystonic posturing, amongst others. Brainstem, you see cross hemiplegia. Facial palsy on the right, left hemiparesis, a crossed one. And then, then of course, in the pons, for instance, you could have deep signs like this, deep coma, capillary meiosis, pupils are constricted, they have hyperpyrexia. When you have posterior fossa stroke, okay, because it's the brainstem will be compressed easily. They're seen as DIC neurologically. DIC in this case is not saying disseminated intravascular coagulopathy. It's talking about death is coming. Okay, so such cases, prognosis may not be too. In terms of arterial territory, you also should be able to see whether it falls into the anterior or the posterior circulation as well. So let's move to the management. If you develop stroke, you have a right to receive best stroke care, be informed, be prepared for your recovery. This table was prepared by my boss many years ago, but we've modified lately. Looking at stroke in terms of phases, okay? The hyperacute phase, which now should be 1 hour. This is talking about the dot to needle, talking about the dot to imaging. Patient gets to the gate of the hospital, and within 1 hour from that time, patient would have had CT scan, and you're ready to thrombolize that individual. So it's really hyperacute, okay? Then beyond that, of course, talk of acute within 24 hours, post-acute after 72 hours. But all this will occur in the first 7 days. Patient is going to die from stroke, they die in the first 7 days. Beyond that, usually extra cerebral complications, so which you need to look out for. Okay, and then you have your early subacute, and then remember that patient with stroke, you need to start implementing preventive measures. I mentioned 3 P's before, but when it comes to management, you double the P's to 6 P. Okay, we're talking about passenger, passage, the power. Then now you talk about the pressure, intracranial pressure that's gone up. So you need to use your mannitol, furosemide, cetazolimide, hypertonic saline. And they also talk about prevention of complications that could set in. Complications of stroke, usually we look at it in terms of 10 Ds, okay? D in 10 places. Most things that start with D, they're not usually very pleasant, except things like mortality. So you have death, 1 out of 3, okay? Disability, 1 out of 3. Depression, 1 out of 3. Delirium, well, maybe 1 out of 10 within the first 4 weeks. Then, of course, dementia, another 1 out of 3 after a second stroke. Then bulk of patients with stroke will have dysphagia. And because they have dysphagia, they also may have dehydration because they're not taking enough fluid. From the dehydration, they could develop deep vein thrombosis. And from the deep vein thrombosis, they could have pulmonary embolization, amongst others. Then they also lying supine, not moving, they could develop decubitus ulcers. So you could look at D at least 10 days will come in. You need to start implementing preventive measures. And then, of course, patient that has had a first stroke doesn't mean they won't have a second stroke. So you need to have a secondary prevention. And that's when you give your statins, your antiplatelets, amongst others. That's like secondary prevention. There's primordial prevention, which is applicable to both communicable and non-communicable diseases, okay? Make sure that patients do their normal exercise, no alcohol, no cigarette, less salt, less sugar, okay? And then they take a lot of fruits, a lot of grains, fish, and water. That's primordial. Then, of course, primary, I'm hypertensive, I'm diabetic, dyslipidemic, I need to take my medication. Hypertension is the leading cause. If you control it, reduce the stroke risk by up to about 40%. Okay, that's primary. Then tertiary prevention, patient present early enough to the stroke unit, you're able to reduce mortality, you're able to reduce morbidity as well and improve the outcome. Then quaternary prevention relates to your therapeutic options in terms of which medication to use, but that will be dependent on other comorbidities as well. So you follow this step. So the stroke care must be in phases. We need to look at it from pre-hospital, from the time of ictus. So 6R must come in. You need to recognize, okay, from the BFAST you've seen, your reaction make ambulance service available, and then your response at the emergency department. Then you do your CT scan to reveal. and then your treatment, and then your rehabilitation will follow suit. Well, we need to fly now. I think I have about just 10 minutes more. It's already said that time is brain, and there are 200 billion neurons in the brain, and every 1 minute you're losing 2 million, and that's 12 kilometer fiber length. So time is of essence.
My friend, time now. Here in the day, let's become with your work. Yeah.
Okay, so that's the take-home message, that time is brain. I'll fly through in the next 10 minutes so we can round up. I know my time is almost up. Stroke units is sine qua non, and then you try to approach the 6H. Hydration, hypoxia, hyperglycemia, hypertension, hyperpyrexia. You must do that, and then you have a coordinated multidisciplinary team. Those are some of the investigations which you need to do, your imaging, including your angiography as well, your CTA, and then you do your blood workup. You check for the for any cardioembolic stroke, atrial fibrillation, amongst others. Okay, so imaging CT is a sine qua non, and all those other tests are listed, including angiographic studies as well. Biomarkers, just to liken to what the cardiologists do for MI, they check for LDH, CPK, and troponin. For stroke, we have some serum S100 beta as well as the SGFAP for ICH. But the truth is that they're not usually available within the time frame that you need to make this your acute decision. So in summary of this, for your stroke treatment, minimal, essential, and advanced, that's like the care bundle. Okay, the stroke unit is sine qua non, antiplatelet agents, aspirin, clopidogrel, your thrombolysis. We now have a flare for tenecteplase, but it has to be given as a single dose, unlike your alteplase that you have to give a bolus and then run the remaining one over the next 1 hour. This you give as a bolus, and it's also cheaper as well. Anticoagulation, yeah, if you have things like atrial fibrillation, amongst others. Then you may use that. Neuroprotection, I've mentioned about the neuroplasticity as well, and the vascular thrombectomy when you have a proximal occlusion, and then some craniectomy. So now we talk more of minimal invasive surgery. And then if you think patient has a subarachnoid hemorrhage, you may need to clamp, an aneurysm, you may need to clamp or coil, or actually use a flow diverter, or you put a stent as well. For ICH, the ultimate is to have an agent that will reduce hematoma expansion. The activated factor 7 will do. You must also improve functional outcome, okay? It doesn't improve that, okay? And then for the BP lowering, which of course in ICH, the INTERACT-2, INTERACT-4 study, agree that you must lower the BP if you catch them early enough. INTERACT-4 says within 2 hours, INTERACT-2 says within 6 hours, okay? They'll keep to 140, 90, and if they are below 60, or they're diabetic, but when they're above 60, then you look at 150, 90. But don't even forget that even if you have hemorrhage, surrounding the hemorrhage, you can have perihematoma ischemia, because even the vasa nervorum, vasa vasorum could become compressed, okay? And they also have some local vasoactive substance release. Yeah, this is the 6P that I mentioned before. I've mentioned these first 3 for your passenger, okay? And I've also mentioned the passage, your carotid endarterectomy, and then the power neuroplasticity. And then for this treatment of wrist intracranial pressure, your mannitol, fusimide will come in, and then managing complications, the 10 Ds, which I've mentioned, and then prevention of another stroke, secondary, primordial, and what have you. So I'm gonna fly through the rest. Tenecteplase is preferred. ICH, okay, this is the blood pressure I was talking of with the INTERACT-2 and 3. Then your statins, okay, apart from lowering cholesterol level, They also play a role in terms of the neuroprotective. They stabilize the plaque. They improve endothelial function as well. They improve endothelial function. They have anti-inflammatory properties as well. And then they upregulate nitric acid, nitric oxide as well. So I know my time is up. So they have added advantages as well. I'll fly through. Neuroprotective, neurorestorative, rewiring. I mean, we've made emphasis on that, okay? So I don't need to, I'll just skip that now. Stem cell transplantation has not worked in patients with stroke, okay? Unlike in patients with Parkinson's, because that focuses on just like one cell group in your substantia nigra producing dopamine. In stroke, we have multiple cells affected, okay? And most studies have not been too rewarding. Neuroacetylcholine, tocotriene, hyperglycemia, because you have glucose being metabolized anaerobically because there's no blood flow. So you have more of oxidative phosphorylation rather than glycolysis. A lot of metabolic acidosis that the protein could get denatured as well. And there's non-enzymatic glycation. Glucose is just floating to attach to the protein and alter the function. Then you have advanced glycation end product, which is toxic to the endothelium and also production of free radicals. And then when you have high glucose, it's toxic to vasculature, risk of hemorrhagic transformation is also high as well. And then, so I don't know if there's a message there. In terms of your choice of antihypertensive, just note that variability of the blood pressure is the key factor, okay, that damages, I mean, the peak between the systolic and the diastolic, okay? Let me fly through this. Okay, if you have an anticoagulant-induced ICH, your PCC is your number one option. Your fresh frozen plasma doesn't work. If you have, if it's due to dabigatran, one of the direct thrombin inhibitor, the NOAC or DOAC, diroximab would be your choice. If it's any of the factor 10A, then aripiprazine or andexanate should be your choice. But of course, you give vitamin K ahead of that. Platelet infusion is harmful, okay? Neurosurgical, we tend to opt for minimally invasive surgery if we must. Endarterectomy, they must have it more than 70% for you to want to do your carotid endarterectomy. And you can also do balloon angioplasty or stenting as well. So in summary of this, for the acute stroke unit care, it's a sine qua non. You must do your thrombolysis within less than 4.5 hours. So with the extend study, you could extend up to 9 hours. And for your deep vein thrombosis, a way to prevent DVT, it's not by giving your low molecular heparin or giving your Clexane or what have you. If you do very early mobilization, you also do adequate hydration and the intermittent pneumatic compression, IPC, you prevent DVT, and I think that's the way it goes, okay? Having said that, I mean, there are attempts now to have a polypill that contain aspirin, contain statin and antihypertensive to try to reduce the pill burden in patients with stroke. So in summary, there's high prevalence of incidence of stroke in low middle income countries, low standard level of care. There's need for tertiary prevention. We set up stroke units in most centers, and I think this is coming up as well. And then, of course, we need to look at short and long-term strategies, which we need to implement, okay? And that takes care of from bench to bedside and bedside to bench as well. This came up at the last conference we had just last week in terms of the guideline, okay? But what is saying essentially is all I've said before, and just to emphasize that if you have your primary prevention, you control them well enough, that's good enough, okay? And then just to emphasize for anticoagulation, when you have either non-valvular atrial fibrillation or valvular, you need to use anticoagulation. Okay, antiplatelet therapy are not indicated for such. And you also need to combine your antiplatelet with anticoagulants, okay? Except when you have a mechanical mitral valve. That's the only time you can. Otherwise, it's not ideal to combine your oral anticoagulant with your antiplatelets. And then PFO closure. So this is talking about all we've said. Let's fly through this. Okay, the other thing also worthy of mention is talking about that. Okay, that's double antiplatelet therapy. If you have a patient with TIA, a very mild stroke, you could start with double antiplatelet. Your clopidogrel and aspirin for 3 weeks. Then thereafter, you convert back to monotherapy. So those complications, we've talked about the 10 Ds. Let's fly through now. Okay, death, 1 out of 3, disability, dementia, delirium, depression, dehydration, from dysphagia, DVT, dementia, DVT, then decubitus ulcer, pulmonary embolization, amongst others. Okay, stroke complications. I mean, when you give your thrombolytic agent, don't forget that risk of hemorrhagic transformation is also there as well. And then you could have either hemorrhagic infarction 1 or 2 when you have the heterogeneous with petechiae along the margins, or whether it's within as well. And the homogeneous less than 30% or more than 30% as well. Malignant cerebral edema, one of the things you notice of your stroke patients, they start becoming less arousable. Okay, they now becoming somnolent. And you look at the pupils, there may be an isochoria, inequality in the size of the pupils. Just, oh, there must be some cerebral edema. So you may need to repeat your medical decompression. How do you go about that? You could use your hypertonic saline or use your monitor. You must use monitor with your fructose usually for no more than 24 hours. Beyond that, the risk of rebound intracranial pressure is high. Okay. Then positioning your patient on day 1, like light supine, day 2, 30, 45 degrees, day 3, 90. And then by day 4, they should at least sit out of bed for 4 hours. Well, steroids, incidentally, my boss is here. I did my dissertation on dissertation in stroke. Okay. What we found then was that patients were going to die from stroke, they die earlier. Okay. For those who had dexamethasone. However, if they're going to have survived, the disability might be reduced, partly maybe because the type of edema you have, extracellular viscogenic cerebral edema, due to vascular permeability increase. This occurs later, not in the first 72 hours of stroke, but the type of edema you have first 72 hours is more the intracellular cytotoxic, because this sodium potassium is the pump sodium and water out of the cell. Okay, but it's deficient, so the cell will swell. Dexa doesn't work for such, okay? Then don't forget that you don't give hypotonic infusion in patients with stroke, and they could have CHAD, okay, in the first instance. Then they could have hydrostatic pressure, hydrostatic cerebral edema because of high BP, like you have in hypertensive encephalopathy, or the interstitial when you have hydrocephalus, amongst others. Hypotonia to reduce the metabolic function, open the brain with peak. For venous thrombosis, I've talked about those 3 things, okay, that you must do. Hydration, early mobilization, and then IPC. Dysphagia, you need to look out for food apnea. You must do swallow test, okay? If they try to drink and they start coughing or sneezing, I mean, it's a warning sign they may develop aspiration pneumonitis. Infection, immunity is low, they have the low leukocyte, and when you have to intubate them, you have to put intrauterine, you have to put catheter, okay, urethral catheter. I mean, you try to avoid that as much as possible. Use your pulse tubing, and then of course the hospital environment risk is also there as well. The decubitus ulcer, you need to make sure you turn them every 2 to 4 hours. Some late complications from seizures, particularly if they have a cortical stroke or they have hemorrhagic transformation. I need to see when they have early seizures. It could be because they have an ICH, okay, in which there's extravasation of blood, causing some excitotoxic neurotransmitter release as ion shift. But when you have late seizures, particularly seizures in the elderly, we need to know that patients will have had disabling and non-disabling stroke. If they have had multiple non-disabling strokes, that has left a scar in the brain, and that scar is epileptogenic. So if you see a patient with seizure in the elderly, one of the things to consider is a post-stroke seizures. And also remember that if it affects the cortex, there's hemorrhagic transformation, that risk is high. OSA is a risk factor to stroke, also of poor prognostic factor as well. Depression, 1 out of 3. Also remember that fluoxetine, apart from being antidepressant, will assist in some motor recovery as well. Okay, so in terms of prognosis, those are all risk factors. When you have posterior fossa, it's a DIC, death is coming. Okay, prevention, I've mentioned about all this preventable. Okay, and all this primordial, your reduced salt, your reduced sugar as well. We're advocating that the government should actually have policies that things that contain, food items that contain so much sugar, so much salt, I mean, they should have high tax on them so the patient can get discouraged. Ditto for alcohol, ditto for cigarette smoking as well. So we take a lot of fruit, a lot of grains, fish. Okay, and then those fast food joints, you avoid them because they're salty, they're sugary, they're fried, and they're fatty as well. Secondary aspirin and statin, we've talked about all this, okay? Primary prevention, you have hypertension, you reduce the risk by 40% if you control, amongst others, okay? Comprehensive risk reduction, we've mentioned all this. So your BP, make sure it's well controlled. Your blood thinner, government need policies and guidelines. We've said exercise regularly, at least about 30 minutes, maybe every other day at least. That will assist you to improve your general well-being. Avoid all those fast food joints, okay? The fatty, the salty, and what have you. Okay, smart girl. Mom told her not to touch it. She didn't touch it, but of course she finished the cake then. Being overweight, your BMI, keep it below 25, okay? And then take diet that are low in salt. And then your waist circumference for male, keep it below 40 or 102, and then for female, 35, okay? Your body fat distribution, obesity, you try to maintain the pear, not the apple shape, okay? And then attend the Wellman or the lifestyle modification clinic, and then avoid smoking and what have you. This talking about stroke risk cost cards. I'm gonna round up now. The population-wide prevention strategies, okay? The government need to intervene and reduce environmental risk factors such as air pollution, free stroke riskometer, and give some polio pill, as well as some community health workers, like kind of as giving assignments to them. Key solutions for primary stroke prevention. I've talked about the stroke riskometer, and all the government should have legislation and taxation on tobacco, on salt, on sugar, and alcohol consumption as well. So end with the good, the bad, the ugly. Okay, the bad, okay? The good, of course, has turned neurologists to Jesus Christ of time. They could make the lame to walk. Okay, and we've seen several like that. Misdiagnosis and mismanagement. Patient that had stroke without a CT, like we have had in this patient, some had brain abscess, hematoma, amongst others. And then, of course, CT scan affordability. Well, I don't know the state it is now, but years back was 1 out of 4 that could afford a CT scan. As part of the cultural misconception, this must be mentioned, okay? Stroke is not a spiritual attack. I mean, you must know the pathogenesis to know that it's not so. And they must present early enough within the time window. There's this misconception that don't take patient to stroke because of injection. It's a total cultural misconception. There's a mix-up between poliomyelitis and stroke. Stroke in Yoruba is called romolese, but it affects children. Stroke is called roparose. So they're not the same. What you avoid injection is in romolese, that's in polio, okay, but not in stroke. You need to educate the populace in this regards as well. They need that intravenous thrombolysis, okay, within that 4.5 hours or 9 hours. The national stroke, we should have guidelines as well. So the challenges are enormous, but they're still managing stroke in patients is suboptimal. I mean, stroke units are still developing, and they were working towards it. The problem peculiar to us because of poverty, poor healthcare infrastructure, lack of government program, they have to pay out of pocket. And then the health insurance scheme we have, they're so superficial. Some of them can even see a neurologist, talk less of you managing a patient with stroke. So we need to translate what we've documented from the lab to bench. So we need better arrows. At 4 targets, population strategy, role of physician, managing acute stroke. So in terms of population awareness program, and that's the beauty of this session we're having, you must educate the children as well, because they may be the only one at home. When they see those big fast signs, you can quickly call 911 or raise an issue to that effect. Identify the risk factors and make sure it's well taken. So whatever we do, we must not set a standard too low. I went to my village and I saw my first cousin in his jacuzzi, and I just came back from Abu Dhabi, saw my friend as well in a jacuzzi. And he says, oh, what's the big deal about jacuzzi? I think there is wealth of difference between the two. So I round up by saying, if all you have is everything around you looks like a nail. Lack of data and information, well, not totally true. Lack of tools and equipment, well, that's true in a way. Lack of knowledge and skill, that's not true. We have knowledge, we have the skill. The lack of motivation and incentives, that's a big problem we have presently in the country, and the Japa syndrome says it all. Okay? Okay? And of course, this is the ugly, which of course, remember,
Every day my people they inside bus. Every day my people they inside bus. 49 sitting, 99 standing. Them go pack themselves in like sanding.
So this, I think we need to cross this bridge. Okay, this is the road to success. So if we can't fly, let us run. If we cannot run, let us walk. If we cannot walk, let us crawl. Whatever we do, I think we need to keep moving. We're on the road to brighter future. We want to believe that the struggle, the suffer, the survive, and smile will continue. The 4S. We must salvage our country and be patriotic and stay afloat in spite of all odds. This, I think, is where we're going. We look up to the stroke unit, fully developed, and I say this prayer, that the young chick in the claws of the praying hawk says that she cries, so the world may learn of her plight. He knows the hawk will not let loose, an Igbo proverb. Our merciful God, may those who can change things listen to our plight. Okay? But for where there's a will, there's a way. Strength through unity. Yes, yes, yes. Knowing is not enough, we must apply. Willing is not enough, we must do. And I think we should do. So hand up with this. So I think the lecture is over. So I can hand over the mic. So wake up or wake your neighbors if anyone is asleep.
It's a bit of an odd name, stroke. It's something.
So you can watch this and take it back from there.
Happy, he doesn't have a facial droop.
Yeah, the slides.
Hi, it's Sue in the ER. I have a stroke code. Your run number is 2404813.
76 years old, his first speech, slumped to the ground. Could we get a name?
Harold Devlin.
Harold Devlin. When he got there, he was sitting against the wall. He's able to squeeze his thumbs now, it's pretty much his very weak.
I think the slides are already with
Stroke is a sudden injury to the brain caused either by a blood clot clogging a blood vessel or a burst blood vessel causing a hemorrhage or bleeding in the brain.
Smile for us. Can you smile real big?
There's only one drug that is FDA approved to treat stroke, and that's TPA, or tissue plasminogen activator, and that dissolves clots.
Nice deep breath, sir.
Your right hand.
Sure.
Let's go to CT. It's the strongest medication we have when used early. However, we can't use it beyond 3 hours of onset of symptoms. A CT scan is primarily done to rule out a hemorrhage because you don't want to treat a hemorrhage with clot busting agents.
They wanted to do TPA. There's just no waiting around at all.
Hi, I'm Dr. Brandy.
Can you open your eyes, Mr. Bentley? Can you hear me? Okay, and what you're gonna do? Mr. Bentley? Can you see this picture?
Don't go into anything,
Well, how about this? He is aphasic. He has trouble getting the right words out. Some of them are gibberish, nonsense words. So he's in danger of losing his ability to speak. That would mean he would completely lose his independence. I'd like to check your strength. Hold that arm. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Can you hold that one up? Hold it up there. Hold it. 1, 2, 3. It's a little bit of a drift on one side, so he may have a mild weakness. I cannot give TPA without a history. Here's our TPA. So the family member's input was crucial. We're good to go. 9:54. Okay. Just try and relax a little bit, Harold. It's in. The first week after the stroke, you're still at higher risk to have another stroke. So it's a very unstable situation.
This morning, he was very disoriented, very dizzy, stumbling around, and that's just not like him. The first thing that went through my mind was stroke. I knew time was of the essence, and thank God he got brought here.
And my message would be that call 911. Even though the thought seems to be, I can get you in the car and get you there quicker. Something could happen in that car. Suddenly the person next to you collapses. How are you going to manage that? Anybody could treat a stroke, but we are the certified stroke center. So those medics know they need to start hitting towards sharp response. I've got resources at that bedside, and they are waiting for that stroke code to come in. Stroke symptoms, 911. Time, the clock is ticking.
He called my mother this morning, freaked her out a little bit because, phone rings at 5:45 in the morning. It was him. Where's my glasses? Where's my car?
I think somebody asked the same question. How are you feeling? Are you better yet? And, put your hands out like this for 10 seconds. Yeah, okay. Do that for 10 seconds on your ankles or something.
I rub your stomach and pat your head.
Oh, yeah, just one right after another.
Well, it's amazing. Even 24 hours. Remarkable difference. He is so coherent now. It's just unbelievable. When we were chatting with the nurses last night just about his condition out here, and he says from the other room, "Be quiet out there." I'm like, okay, Dad's back. He's doing remarkably well. I think he's gonna bounce back. He's definitely motivated. He's got grandkids to look forward.
I don't know.
Behind the plate.
So that's the beauty of an acute stroke unit and taking thrombolysis amongst others. Okay. So I think we'll take questions or comments at this stage, and I hand over back to Olamide Oluwatuyi. Okay. For the slides, yes, I already sent them to Olamide Oluwatuyi. So you could just send a request to her, and I'm sure she'll forward it to you. So we take questions and comments.
You want to see?
Yeah, thank you.
Thank you very much, Prof. Right now, I feel passed off. In fact, I'm beginning to feel like a neurologist, just sitting down listening to you. Thank you so much. Like I said before we started, we are going to listen to an erudite professor. So just a brief of the little I was able to pick from this very interesting and educative conversation. It was alarming to find out that 1 out of every 4 would have stroke. Really quite alarming statistics. We moved on to talk about the 3 Ps, where we mentioned the passenger, the passage, and the power. I'm sure the medical community would have taken note of this. And something that is worthy of note is that large hypodense lesions could end up having hemorrhagic transformation. And for those that are non-medical participants on the call, what I believe we could have taken note of from this lecture is be fast, how to identify the stroke. Loss of balance, eye vision loss, facial weakness, arm weakness, speech difficulties, and time is brain, which is very important. Be fast, that is the acronym. As we have learned today, that once you have a stroke, 2 million neurons will die every minute, and time is brain. You need to get to the stroke unit as fast as possible. Then, for those of us in the medical community, in addition to the 3 Ps, another 3 Ps was added: pressure, prevention, and prevention of a repeat stroke. That's the secondary, primordial, and tertiary prevention. We also learned that in the prevention of vein thrombosis, we should ensure there's early mobilization, hydration, and intermittent pneumatic compression. We also learned about antiplatelet, the dual antiplatelet therapy. In acute stroke, you can have dual antiplatelet therapy. That's your clopidogrel and aspirin for 3 weeks before you revert back to the monotherapy. Something that I really picked here today, the swallow test, very important. I lost a very close relative who had aspiration pneumonitis after a stroke. He was already getting better, but a swallow test was not done for him, and he was fed. This led to aspiration pneumonitis, and the sequelae came afterwards, and we ended up losing him. It was quite painful. So let's take note of the swallow test. And something that is very important for me that I learned here today, fluoxetine, which is an antidepressant. Of course, when we talked about prevention of complications, I forgot to mention the 10 Ds, of which depression is part of the 10 Ds. Fluoxetine is helpful in treating the depression. And most important, it also helps in some motor recovery. And finally, we talked about 4 S, struggling, suffering, surviving, and smiling. Well, Prof played the Suffering and Smiling song by Fela for us. So I think I will end my summary here, and we will take questions now. So please, if you have questions, raise up your electronic hands. And before then, I will look
for your brilliant summary. Yeah, I think you pick up the highlights. Well done. Go ahead, man.
Okay. So I would go through, please raise your electronic hands while I go through the chat box. Yes, the chat box, many people are saying thank you, brilliant presentations. Quite a number of people are requesting for the slides, and I'm sure Dr. Busuyi would help get the slides to everyone that needs it. And I will take the question in the chat box first. So, Harry Houdo asks, thank you, Prof. Please, is there any advantage to MRI? Let me see if there are any more questions so that Prof can take the questions in the chat box first. Okay, thank you. Okay, another question. What is your take on MRI at diagnosis in patients with suspected stroke? This is from Dr. Sakina. When do we use antihypertensives in stroke? At what mean arterial pressure? What are the evidence for the use of neuro aid? I think we should do those 2 first so that we are not lost in our tracks. Thank you, sir.
Okay, thank
MRI,
you. I think the first question, thank you for Sakinat. Okay, that was my take on MRI diagnosis in patients with suspected stroke. Yeah, I think the point of emphasis is this, and this is my position as well. When patients come in to see you with the first signs, okay, balance loss, eye vision loss, facial asymmetry, arm weakness, speech difficulty, your imaging of choice, you want to make a clinical diagnosis and make a pathological diagnosis. And the reason for your pathological diagnosis is to say, look, this patient has an infarct, okay, so that you can quickly thrombolize and reverse it as it dries through. If it has a wet stroke, there's no need for thrombolysis. You need a time frame. And that's why we said the hyperacute phase is 1 hour. That's what we call the dot to imaging. That's what we call to dot to needle. Okay. Dot to imaging, you get to the hospital of Lasuth, and within few minutes, 20-25 minutes, you have done a CT scan, and then you have your report ready. You're able to start the thrombolysis, dot to needle, within that 1 hour time frame. The time frame you need for CT scan is a lot shorter compared with MRI. And MRI is not even available in most centers anyway. In a village in Ikorodu, I can say, for instance, if you need to do an MRI, you have to send the patient all the way to Ikeja. So that time frame is not there. Be that as it may, if I have a patient, so your reason for doing that immediate CT scan, 4 reasons why you're doing that. The first reason is you want to exclude a stroke mimic. That's number 1. 2, you want to exclude hemorrhage. Okay. 3, you want to exclude a large infarct. Well, if you have a large infarct, risk of hemorrhagic transformation is high. I could have been there for a longer while. Your time window we're talking of is 4.5 hours from the onset of the stroke. It's only lately that we have the extent study that extended it to 9 hours. So you can imagine that time is of essence. Okay. So if you need to thrombolyze, fine, you have a normal CT, then go ahead and do your thrombolysis. However, if the patient is presenting late, okay, maybe later than maybe 72 hours or a week, you're not going to thrombolyze for any reason. Your MRI may then be indicated to save the patient cost, because if you have an infarct, a posterior fossa infarct in the brainstem, your CT scan will not pick that well enough because of the bony artifact that you have in the brain, in the posterior fossa. So in such a case, MRI is what you should opt for, okay? Or the patient has had a seizure as well, had a convulsive or non-convulsive seizure. There's no point doing CT scan. Once the seizure comes in, then go ahead and do your MRI. The MRI will pick, among other things, what we call MTS, mesial temporal sclerosis, okay? So I think that clarifies that. Okay, if a patient doesn't come within that time window, there's no point. The time window of reference, your thrombolysis, first 4.5 hours, extent study 9 hours. You also need to do your endovascular thrombectomy. Okay, you need to do this with the done within 24 hours. Okay, if it's the diffuse 3 study, 16 hours. So if anybody coming beyond that, I mean, there's nothing else. And if you think it's a posterior fossa stroke, you can do your MRI. I think that clarifies that. The second question relates to when do you use antihypertensive in stroke? Well, I think I'll just recap what I've said, okay? There's a place for permissive hypertension, particularly with reference to cerebral infarction, okay? In cerebral, intracerebral hemorrhage, okay, I've mentioned 2 studies, the INTERACT-2, the INTERACT-4 study. The INTERACT-2 study was done years back, and they came up with this decision that if you catch the patient early enough, patient is below 60 years old, okay, drop the blood pressure to 140/90, or patient is diabetic. Is above 60 years old, drop it to 150/90 within 6 hours. The INTERACT-4 study came up lately, and as I even said, this must be done within 2 hours. That is for ICH. When it comes to cerebral infarction, okay, we talk of permissive hypertension, and I gave 3 reasons why you need to do the permissive hypertension to still allow blood to flow. Remember that cerebral infarction will only occur in the absence of adequate collateral circulation. Okay, those collateral circulation are the back doors. If you need to keep those back doors open, I told you of 3 categories of the back doors. The first category is your circle of Willis. Second category is your leptomeningeal vessel and the ophthalmic artery. And then your third category relates to your new vascularization or angiogenesis, when you have new vessels being formed by agents that will stimulate what we call vascular endothelial growth factor, okay? And that explains that. And then the third reason I gave also is because I've lost autoregulation, okay? The cerebral perfusion is now pressure passive. Autoregulation says the brain is 2% of the body weight, takes 20% oxygen, takes 20% blood volume, and it doesn't want any extras. Okay, if the mean arterial pressure goes up, it will vasoconstrict. It doesn't want overflowing of its circulation. Mean arterial pressure goes low, it will vasodilate to allow cerebral perfusion. So where you've lost this autoregulation, and this can be on up to about 3 weeks post-stroke. Therefore, your perfusion cerebral perfusion is now pressure passive. That's the second reason. The third reason, of course, is the equation which I also give, that CPP equals MAP minus the ICP. ICP must have gone up because of either extravasation of blood in hematoma. We have significant cerebral edema. So if ICP has gone up and you want to maintain CPP, then your MAP must go up, okay? Well, ideally, the MAP should be about 70 or thereabouts, your MAP about 100, and then your ICP about 30. Then the question on that, the double antiplatelets therapy, well, basically, it's indicated in patients that have a TIA or a very mild stroke, and you give for the first 3 weeks. Beyond that, just reduce back to your single therapy. I mean, the details are on that slide, which I'm sure we'll share with you as well. Okay. Okay. There's also a question here. Well, we see some compliments in here as well.
Sir, the next question is, what is the role of lactose in stroke management?
Lactose, the only thing lactose, the best I know, is that it's like a laxative to prevent you from straining. What I could say is this: there's what we call the Valsalva maneuver. Okay, when you have to strain or you have to sneeze or cough repeatedly, because the risk of, if you have a Charcot-Bouchard aneurysm, for instance, okay, during such whatever, we've had patients that the time they develop the stroke is when it occurs when they're in the toilet. Okay, they're just trying to strain to pass through or strain to pass urine or something, and then this thing will come up. Okay, the relevance in patient with stroke will be relevant when you have a patient with subarachnoid hemorrhage. Okay, because in patient with subarachnoid hemorrhage, you're going to keep them for 6 weeks. The first 3 weeks mandatorily must be in the hospital. And one of the things you want to avoid for them is that they should not strain. Okay, even cough, they develop it, or they start sneezing, you have to quickly treat. But any attempt to do all this will aggravate the hemorrhage. I think that would be the relevant. I think it's just a stool softener in that regards. Yeah. I don't know if I've attempted all the questions.
Yes, sir, you have. Thank you.
I put email here as well. So if anybody needs my email, I'm available.
Thank you so much, sir. We will do well to share the slides and also your email address to all those that need it.
Yeah.
Thank you so much. We are done with the questions in the chat box. I can't see any electronic hands raised. So thank you so much, Prof. Okay, Dr. Nwako, please go ahead, ma.
Good evening, ma.
I can see your hands raised.
I raised my hand before.
Okay.
Thank you, ma.
Go
Good
ahead.
evening, Prof. Please, I have a case that I'm actually managing that I wanted to bring to your notice. I have a patient with a recent stroke. It was minor. She recovered, but then she also has symptomatic peripheral artery disease, very painful claudication when she walks. So I wanted to know, she's already on all the medications to manage the stroke. She's on, she's getting her antiplatelet. She's on some atorvastatin, and then she's also on citicoline and all of that. But then I wanted to know, can you still give her cilostazol? at that time, because then that will be using the data again, because Losazole is also an antiplatelet. Can we still do that? And because her stroke is now more than 3 weeks and she's recovering well, so can she still get like the double anti-platelet therapy, or would it be dangerous at this time since her own stroke is more than 3 weeks and she's recovering well? Because initially, yes, sir.
If she's recovering well, I mean, it's not absolute, okay, at this stage. But the question to ask is, have you done a Doppler?
Yes, sir. A Doppler was done. It confirmed severe peripheral artery disease on both limbs, and she's having claudication.
Okay, and is also on statin as well.
She's on statin, yes, atorvastatin 40 milligrams daily.
I think that should do. What's the extent of the narrowing on the Doppler?
Well, I don't have the result off my head, but it says severe narrowing. That was what was mentioned. So, I just want to let you know what I did, because initially I started on Silostazol and her pain reduced. Then I stopped this platelet therapy, or would it be dangerous at this time since her own stroke is more than 3 weeks and she's recovering?
No, if she's recovering already, I think just leave her on the single antiplatelets, okay? And then with the statin, high intensity statin will be indicated at this stage. I don't know which of the statins you are giving.
She's on
atorvastatin or atorvastatin. I mean, either of these two will be good enough for her as well. Okay.
All right. Thank you.
My pleasure. Then, sorry, there was a question on NeuroAid, which I think I left off. Yeah. Yes, it's the NeuroAid has to do with neuroplasticity. And like I said, if there was anything we have ignored before now, the emphasis had been on the passenger and the passage. Okay. We had ignored the brain itself because we felt the brain cell do not regenerate. Now we know, even if you're 200 years old, there's still some neuroprogenitor stem cells in the periventricular, subventricular region of the brain. And those stem cells can be stimulated by BDNF stimulants. Okay? There'll be axonal sprouting, the axon will sprout. Synapses that have been inactive, they become activated. So there's synaptogenesis, there's axonogenesis. This combined together is neurogenesis. So there are new neurons formed. Okay? New neurons are formed. Neurons will not survive if there's no blood flow. And that's why we recognize the cardiologist, the neurologist, and others in the medical subspecialties. So, having said that, NeuroAid also stimulates what we call the VEGF, the vascular endothelial growth factor as well. So if that is stimulated, then there will be angiogenesis, there will be new vascularization that it can sustain vascular unit hypothesis. Having said that, it's a medication you need to take at least for about 6 months in the black skin, because our stroke is more severe. The outcome is also poorer as well. And this has been documented several. In the white skin, yeah, they may say 3 months or thereabout, but the black skin from our local experience, I think that works, okay? So it's been a reputable medication, so to say, all right? Give us your own take, understand how to manage ourselves. Well, there's a question here, Dr. Oluwatoyi, please, there are non-medical personnel here. Please kindly give us our own take home in a way we understand on how to manage ourselves. Well, I think she had simplified it, but I think the question is for Oluwatoyi as well. But honestly, and truly, she gave a very brilliant summary of what I've said as take-home messages. But I think if I say it in my own word, I think it's prevention, prevention, prevention. Prevention is not only cheaper. It's not only cheaper, I mean, but certainly better than cure for whatever reason. I will emphasize the prevention, the primordial one. Make sure you do your exercise, avoid obesity, no alcohol, no cigarettes, less salt, less sugar, okay? All those fast food joints, I mean, should not be your portion. Take a lot of fruits, a lot of grains, including fish as well, okay? If you're hypertensive, that's primordial. If you're hypertensive, make sure it's well controlled. You reduce your stroke risk by up to 40%, okay? And if you have diabetes, make sure it's controlled. Cholesterol is controlled as well. And I think that's the emphasis for you. If you have had a stroke before, then you need to prevent the reoccurrence. then it becomes mandatory. They're going to take your aspirin or clopidogrel lifelong. And then you may need to add your statin as well. Statin is also compulsory that you must add as well for secondary prevention to prevent another risk as well. Well, tertiary one, will not be applicable to you because that means an acute stroke that needs an immediate attention as well. And if there's a strong family history, you need to be wary as well. Just make sure that at least you observe all this we're saying. And then, of course, avoid stress too, as much as possible. Okay? We know the country is stressful at this time, but then what can we do? Okay? God will take absolute control. Yeah.
Amen. Thank you so much, Prof, for bailing me out.
Yeah,
I saw
it in a simple language.
I thought I saw Dr. Richard's hands up. I can't see it anymore. Dr. Richard, do you have a question?
Good evening, Prof. and all our senior trainers on the call, as well as our moderator. No, I raised my hand to call your attention to what Prof read out. People that wanted to get their own take home, that they are not professionals on the call. Thank you.
Thank you so much, sir. Yes. I also want to ask one question, sir. On your slides, when you were talking about the risk factors, I saw memantine and atorvastatin on the same page as the risk factors. I just wanted to confirm that are they known risk factors?
Memantine and
atorvastatin.
Known risk factors under which one? Will it be under hemorrhagic ICH? Will it be under that?
Probably, sir. It was when we were discussing the risk factors.
The risk factors. Except I go back to the slide to be sure we're on the same page. But if it's the statins, one of the things which we've said of statins is that there's that very low risk of hemorrhage. So in other words, when your cholesterol is high, there's increased blood viscosity, there's tendency to thrombus formation. That is taken. If your cholesterol is low and too low, there's a low risk there of hemorrhage. Very low risk. Okay, maybe that's why you saw it there. And I'm sure there would have been a question mark in front of it. Okay, that's why statutorily, if a patient has an intracerebral hemorrhage, you don't give them statin, except if there are other co-founders that do not have your dyslipidemia. Or like a patient with cerebral.
You're rounding it. Okay.
Yeah, that have to upfront, you need to start them on your statin as well.
Thank you very much, sir. We appreciate your presence on this call, and we appreciate your honoring our invitation. Let's not forget that this is organized by the Hypertension Awareness Forum, and you can follow them on YouTube at Dr. Busui, on Instagram at Dr. Busui05, on WhatsApp on 08039537445 for regular information on hypertension. Thank you once again to our attentive audience. We will take the closing remarks now by Dr. Busui. Thank you.
Thank you very much, man. Thank you very much, sir, for accepting this, even without seeing my face. All the conversation were on the WhatsApp. I was actually taken aback because I've actually tried to get this done last year, but the person I spoke to, you don't even respond to my chats. But I'm so excited that you responded and you are ready to do it. Even this is the second lecture you are giving today, and I appreciate this much, sir. And then Dr. Luwatwi, thank you very much for taking the job of being the moderator. And I appreciate every one of us that have joined the call today to learn more about stroke. And we have learned things that we need to do. And we all need to be the vanguard of this information all around us. when people have stroke, you need to tell them the first thing to do. In the course of starting this forum, I've had about 3 people that have had stroke. Fortunately for us, both of them were mild, and initially they called me. The one just woke up. One of them was a pastor. He just woke up and said, "Doctor, I can't carry one leg, I can't carry one hand." I said, "Please, immediately go and do a brain CT scan. Go to hospital. He went to the hospital." And that is very important. What got to the hospital said there's nothing much. We are fine. I told him that no, you must do a brain CT scan. He eventually did it. He was able to advise him but the problem was that because the first hospital he went to had given me a false impression that it's not true. So every other thing was saying was just he didn't take it serious. So, but fortunately for him, he just has a subtle hemiparesis that was managing coping with. That's why we need to take information to the grassroots that people should. As doctors in the hospital, we need to know what to do. I had a similar experience too for a man. This is a man that is elderly. The daughter works in a stroke unit in UK. So eventually, the daughter was calling. Immediately, the father told her that she had a stroke. It's okay, go to the hospital. He got to the hospital. The doctor did not diagnose the stroke, despite the effort of the daughter. Eventually, the daughter had to move the man from the hospital to another hospital, and the daughter had to fly in from UK. But by the time he came in, the man has become paralyzed. He had dysphagia, so they had to do a peg. The man had to become bedridden, and eventually the man died shortly after. So, as doctors in working in all this area, we need to be able to identify and be able to ask people to do this investigation. Doing this CT scan is what taking a loan to do, because if you can do it and you can get the treatment as we have been informed, then the person can live to work to repay the loan. But one person is disabled, he can no longer work, become a vegetable, then his source of livelihood is gone for most people. So we need to continually encourage, educate ourselves to know what to identify these things and quickly refer to the appropriate gutters as much as possible. So thank you very much. I will end there, and then all of us that send our emails, the slide will be sent to us, and anyone that need more information can always contact. And these things also we can all be vanguard in our communities. On our WhatsApp group, we can always gather people that you know together and let's be educating them, because like Proverbs say, prevention is also of essence. We need to continually educate our people on what to do. And once they have this, we need to get them to the hospital as fast as possible. Thank you very much. I will end there.
Thank you very much, Dr. Busoi. We have come to the end of today's discussion on stroke. Thank you for attending, and let's all have a good night's rest.
Thank you, sir. Thank you, ma. So we end the call now, ma. Sas. So
thank you. Good night.
Thank you very much.
Good night.
Thank you, Sas. Thank you, Mas.
All right. Thank you very much, everyone. Enjoy.
Thank you very much. We're expecting the slide, please.
Thank
you, sir. Thank you, sir.
Thank you, Prof.
Thank you, ma'am.